Welcome to The Explainer. Today, we're going to break down a landmark trial every vascular surgeon really needs to know inside and out, the GALA trial. Okay, let's dive right in. Just imagine the scenario, right? You're in the hot seat, the examiner leans forward, and that's the exact question that comes up. Your time starts now. This explainer is all about giving you that perfect, consultant-level structured answer. We're going to approach this exactly how you should in your exam. We'll start with the clinical question, walk through the methods and the results, offer a solid critique, and then wrap up with its clinical impact and, of course, a model answer. Right, Section 1, the clinical question. Before we even get into what the trial found, we need to understand why it was done in the first place. I mean, why was a trial on this scale even necessary? Well, the background is pretty straightforward. Carotid endarterectomy, as effective as it is, still carries some pretty significant risks around the time of surgery. So the real problem GALA was trying to solve was, how do we make a proven procedure even safer for our patients? And that led to this, the central clinical question. The theory, the thinking was that if you could keep the patient awake under local anesthetic, you could monitor their brain function in real time, and that might lead to better outcomes. GALA was designed to answer that question once and for all.
Okay, so let's get into the trial's architecture, the nuts and bolts. Understanding the methods is absolutely non-negotiable if you want to properly critique the results later on.
So here are the key facts. And you got to take note of the scale here. This thing was massive. A huge international effort with over 3,500 patients. It was a prospective, two-arm, parallel group randomized controlled trial. The highest level of evidence we can get. The trial was comparing two fundamentally different approaches. And the key difference, from a surgeon's perspective, was the ability to directly test neurological function during the carotid clamping in the local anesthesia group. And that, as you can see, led to a much, much lower rate of shunt insertion. So, with that design in place, what did the trial actually show? This is the most important part of your answer, so listen up. First, what were they actually looking for? Well, the trial looked at a combined primary outcome, grouping together the most serious bad things that can happen right around the time of the surgery. And here it is, the headline result. The primary outcome happened in 4.8% of the general anesthesia group and 4.5% of the local anesthesia group. I mean, just look at those bars. The rates were almost identical. This translated to a risk ratio of 0.94, which, suggests a very slight but non-significant trend in favor of local anesthesia. But, and this is the crucial detail, the 95% confidence interval was 0.70 to 1.27. Because that interval crosses 1.0, we just can't rule out either benefit or harm. And that means the result is not statistically significant. That is the key statistical takeaway you have to mention. Okay, so a good Viva answer doesn't just parrot back the results. It shows you can critically appraise the evidence. So let's take a deeper look at the trial's limitations. Mentioning these points shows a much more nuanced understanding. The most important critique is that the trial was underpowered. And it's a bit of an interesting one because the complication rate was actually lower than they expected, which is great for patients, of course, but it made it statistically way harder to prove a difference. That pragmatic, non-standardized approach to technique is also a valid point of critique, though it was probably necessary for recruitment. So, given this neutral result, this statistical draw, what was the actual takeaway for surgeons and anesthesists in their day-to-day practice? Well, the main impact was just providing clarity. GALA gave us really strong evidence that for the average patient, there is no big safety reason to routinely prefer one technique over the other. And what that did was empower a much more patient-centered approach. It meant the decision could be based on patient preference, their other medical problems, and of course, the experience of the local clinical team. All right, let's synthesize all of this. Let's pull it together into that concise, structured answer that you're going to need for the exam. Here's your framework. This is your blueprint. If you follow these 5 steps, your answer is going to be logical, it's going to be comprehensive, and it's going to hit all the key points the examiner is listening for. And to finish up, here is that polished summary. This is what ties everything together neatly. Delivering an answer just like that shows you haven't just memorized facts. It shows you truly understand the evidence and how it applies in the clinic, and that demonstrates the kind of judgment that's expected of a safe, competent consultant.